A little bit about LTCCC, for those of you who are not familiar, we are a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in nursing homes and assisted living. Our focus is on policy research and analysis, and we use that as a basis for systemic advocacy. And then more and more over the past dozen years or so, we've been focused on public education. We're also focused on public education, including programs like this and a lot of the resources, fact sheets, the data that I mentioned earlier on staffing and on antipsychotic drugging that we have on our website. Everything is free to use and share. And lastly, we're also the proud home of two local long-term care ombudsman programs. Without further ado, I'm going to introduce our speaker today. Professor Robert Tyler Braun is with the Weill Cornell Medical College, and I've known Tyler for a number of years now. He's done some really exceptional research on uh, financing and in particular private equity in healthcare. And he's going to talk today about shedding light on nursing home industry spending and profits. The materials from today's webinar are posted on the website, and the program itself, recording, will be posted by the beginning of next week. Here's a little bit more about Tyler. And one last thing about our event. Actually, this is my ending. Sorry, Tyler, I'm going to hand it over to you and stop sharing.
All right. Yeah. Share my screen here. I'll make sure I can do that real quick. One sec. All right. Can you all see that?
Yes.
All
Yes.
right. Well, Richard, thank you for having me. I really appreciate it. My name is Robert Tyler Braun. I go by Tyler, go by my middle name. People tend to get confused, but you can thank my parents for that. Today, I'll be talking about finances and capital investments in nursing homes. So what I'm going to be presenting today is kind of a myriad of studies that I've done over the past couple years with a lot of great colleagues. And before we jump into that, I want to just make some acknowledgments here. Without the funding from NIA, the Long-Term Care Community Coalition, and Arnold Ventures, none of this work would be possible. And so for agenda today, I'll be talking about the financials and the capital structure in nursing homes, just a basic overview, a brief history of mergers and acquisitions in the United States, some of these merger strategies, private equity and REITs, an overview, and some of the evidence. As you know, it's a hotly contested topic right now, especially with these types of institutional investment. So I hope today is informative, and please feel free to reach out at the end if you have any clarifying questions or remarks. So first thing I like to start off is what makes nursing homes different from other healthcare settings? They're very different, right? It's the only Medicaid long-term care benefit that federal law requires state Medicaid programs to offer. It's also the only care environment in which healthcare dollars through Medicare fund housing, right? And more than half of their revenue from federal and state government sources, Medicare via fee-for-service, Medicare Advantage, and Medicaid, deliver medical and long-term care benefits within the same building, right? No other service line or industry in the healthcare setting is quite like this. And what are the challenges for nursing homes, right? They're increasingly serving a more complex patient population. They're battling increasing hiring and retention costs, and they're struggling with an increasingly tighter reimbursement environment, mainly Medicaid, right? And just, I want to put this visual here. This isn't published anywhere, but hopefully soon. Looking at the average operating and total margins of nursing homes from 2011 to 2021. And then you see that big spike there in 2019. We back out COVID-19 funding. So that dotted line represents if they didn't receive COVID-19 funding, emergency funding, this would be their average total margin, right? And with the total, with that funding, right, those solid lines represents it with COVID funding, right? So you've seen a declining rate of operating margin and total margin throughout the years, right? And this is obviously like a very contested, topic going forward of like, are nursing homes actually hiding or tunneling their money to hide profits and not pay taxes, right? And So the ultimate question here is, how did we get here? So there's been policy events, unfolding over a 30-year time frame, which have shifted the nursing home industry from one of long-term care market dominance, favorable reimbursement, and rapid growth fueled by debt financing, to a challenging business environment that requires increasingly creative strategies to raise capital and finance basic operations. The shift from cost plus to Medicare prospective payment and subsequently to a value-based reimbursement environment, along with growth in lower reimbursement MA or Medicare Advantage volume, has over time reduced the commitment of federal and state governments to cover nursing home costs, which has made it more difficult for operators to obtain affordable private capital to fund long-term investments. And so we tried to shed light on this in this paper that I actually co-authored with Richard, Charlene Harrington, and Dunk Williams at a Medical University of South Carolina. And what we did is we looked at the United States nursing home financing, spending, profitability, and capital structure. Now, I'm not going to go through everything in this paper because it's very dense, but I want to just kind of give you a highline overview of what we actually found. So in this table, it reflects, substantial financial activity in U.S. nursing homes. This table gives an overview of, facility utilization, finances, and patient mix of about 12,000 nursing homes. And on average, each facility has about 115 beds. And in terms of the care provided, the average number of Medicaid patient days per facility is around 18,000, while Medicare days was about 4,000. And showing Medicaid use is obviously, or Medicaid occupancy is much higher. And there were also about 12,000 days for other patient types, making a total inpatient days an average about 34,000 per facility, and with an average occupancy of around 81%. And so financially, the average nursing home reported about $10 million in net inpatient revenues and an additional $722 in other income. So this leads to a total net revenue of around $10.75 million, right? So it's a considerable chunk of change. And they also reported expenses averaging around $10.69 million, of which about $546,000 on the average were disallowed. So leaving allowable expenses at nearly $10.15 million. So after accounting for depreciation costs, the average allowable expense without depreciation was about $9.81 million. Okay. And we'll get a little more into this stuff later on if it's not making too much sense, but just bear with me. And then this table, we're examining the financial performance of these nursing homes. Right, the net income from inpatient services shows an average loss of around $727,000, with a lot of significant variability and total loss of about $7.37 billion. So, however, when considering all of these services, the average net income is a profit of around $62,205 per facility, totaling about $730 million across the entire sample of the 12,000 nursing homes that we looked at. And then the net margin, which is the profit as a percentage of total revenue, stands at about 0.5%. Okay. But when you dive a little closer into this, when adjusting for disallowances, which are expenses not accepted by Medicare for coverage, the average net income increases to $598,000, and the net margin improves to 5.66%. And then after you adjust for depreciation, that net income rises to $936,000 with a net margin of 8.84%. So I just lay those three numbers out there for you to kind of decide what you think, for your own interpretation of what to gauge what you think the actual profitability of a nursing home is. And one other note is these adjustments suggest that without accounting for disallowed expenses and depreciation, the financial health of these nursing homes appear to be a lot more robust. Okay. Another thing here, this table shows you a snapshot of the financial health of those 12,000 nursing homes in 2019. And so on average, each nursing home had total assets of about 13.1 million, with a large variation indicated by that, the standard deviation of 30.9 million. All right. So in total, these nursing homes had a combined asset value of about 154 billion, which comes when that comes to liquidity, the average nursing home had about 875,000 in cash or in banks. All right. And then when you look at liabilities, the average nursing home had about 11.5 million in obligations, contributing to a total of approximately around 135 billion in liabilities across the nursing home sector. So the total fund balance, which can be thought of as like net worth, right, averaged about 1.6 million per nursing home, which totaled nearly about 19.1 billion across the sample. And so two key financial ratios that give us insight into these nursing home financial structures, the debt to capitalization ratio, which was about 52.45%, showing that more than half of nursing homes' capital structure was financed through debt. And then the debt to equity ratio was 3.2 on average, meaning that for every dollar of equity, there was $3 of debt. This indicates a relatively high level of debt compared to equity across nursing homes, with considerable variability as shown with that high standard deviation. Another thing too is you could actually see that if you go back to the other table and you look at total revenues, doing liabilities over total assets, most of this is 90% of nursing homes are financed through debt, which is not considerably a bad thing, but just something to take a look at. So let me jump to that. And so this brings me to the ultimate question of what are the capital options for nursing homes, right? You have banks, you have tax-exempt bonds, nonprofit, that's especially relevant to nonprofits, and then you have HUD 232 loans. And they're often, historically known as the lender of last resort, typically because it's a slow, laborious process, and there's a lot of financial metrics that you have to hit in order to get one of these HUD-sponsored loans. And then there's the institutional investment, right? These could be private equity firms or real estate investment trusts, right? And I always bring this up because we were historically in a low rate environment, interest rate environment. And as a result, local, regional, national banks we're providing, attractive loan rates. However, this is a challenge in working with banks and making sure that they understand that healthcare's specific business model. So banks often manage risk by requiring a significant equity contribution and by providing loans with interest rate resets. And I always say, right, if you want to go to your local bank and get a loan and you only have an operating margin of, 0.5%, you're probably not going to get a loan from them, right? And that probably disqualifies you from a HUD-sponsored loan as well, right? So if you are struggling financially and you're trying to keep your lights on, institutional investment, such as private equity firms and real estate investment trusts, might actually be an ideal fit, right? Well, not an ideal fit, but one of the last ways that you can get an infusion of capital to modernize your facilities, pay for your staff and your operating expenses, right? And so we have this current financial climate within nursing homes that is highly contested, and especially with the movement of institutional investment in nursing homes. A couple of years ago, President Joe Biden mentioned that as Wall Street firms take over more nursing homes, the quality in these homes has gone down and costs have gone up. That ends on my watch, right? And so the Biden administration, along with CMS, has taken a proactive approach to trying to create more transparency and ownership of nursing homes, be it with ownership as well as in the financial space. We'll get more into that later. And I'm going to talk about some studies that we completed that indicate that when institutional investment comes in, nursing homes might not necessarily understand what they're signing up for, and costs go up and quality goes down. So you might be asking yourself, what is private equity, right? These are private investors that invest capital in private companies, and then they receive a controlling equity stake that is not tradable on a public stock exchange, right? So you might be asking yourself, well, how does this work? Well, before we get that, let's just talk about the goals of private equity, right? When they acquire a nursing home or any healthcare organization, they control the majority of the economic and voting interests. And then they restructure the financial, governance, and operational characteristics to increase profit, right? And then they try to sell or flip it in 3 to 7 years, and they expect a return on investment of around 20%. And so this is the typical, no two private equity firms are the same, but this is a basic illustration of how private equity is structured. See that black box there? It says private equity fund. That's the LP, or the limited partners, right? This is a shell company or shell organization where it's steered by a general partner and individual fund managers. They're the ones that guide the fund's direction, the private equity fund's direction, be it that they have a portfolio of strictly healthcare companies or nursing homes. It could have commodity companies, oil companies, energy companies, whatever. And then what they do is they go out to outside investors, be it mutual funds, high net worth individuals, pension funds, to infuse capital into the LP. And then the general partners and the individual fund managers go out and find companies to acquire. And the companies that they acquire are typically what we call their portfolio company. And depending on the private equity firm size, you could have, 2 or 3 companies, all the way, upwards of hundreds of companies. Okay. And so private equity markets are typically defined in 3 ways, and I think of it as a pyramid. There's the lower middle market, which is typically annual revenues between 5 million and 50 million. There's the middle market, and then there's the upper middle market. And so in the lower middle market, you have these smaller private equity firms that acquire individual practices, nursing homes, hospices, home health agencies, right? And then in the middle market, after they've acquired, let's say 15 or 20 nursing homes, they roll them up into a platform company. And that platform company then is acquired typically by a larger private equity firm. But there are these big nursing home chains. These can be large practices, nursing homes, hospice, home health, right? And then ultimately you go to try to sell to the upper middle market, or essentially maybe later on becoming publicly traded. Okay, so I think of them in those 3 defined markets. And this is just kind of a conceptual overview of, what happens when it says hospice here, but you can apply this to nursing homes as well, is that a private equity firm or a publicly traded company will acquire a platform organization, which is typically well regarded in the community. And then they make individual acquisitions of nursing home facilities, right? And then they roll them up into that platform practice, right? And basically the platform, along with the private equity firm, align their interests, and they have a sense of urgency because they typically want to sell in 3 to 7 years, to extract as much profit as they possibly can, create economies of scale, create efficiencies where they see fit. So these roll-up acquisitions, a little more on this, all right? So when you make an acquisition, they're basing the value on this thing called EBITDA, right? Which is earnings before interest, taxes, depreciation, and amortization. Essentially, think of this as a proxy for operating cash flow, all right? And then the PE firm focuses typically on fragmented markets to consolidate. And as you know, nursing home, the nursing home sector is pretty fragmented. Even though around 50% of nursing homes are in chains now, but that other 50% is still very fragmented, right? And this allows them to create economies of scale and consolidate, all right? And then what they do is they generally acquire this platform practice first, and they typically the PE firm pays 8 to 12 times the EBITDA for a platform practice. And then they use that platform practice to recruit new clinicians, acquire smaller practices or nursing homes. And then those smaller practices typically are 2 to 4 EBITDA, okay? And then through this thing called multiple arbitrage, that small practice or a nursing home becomes the value of the platform practice, okay? So you might be asking yourself what multiple arbitrage is. To not try to make it too confusing, this refers to the increase in the valuation multiples that can often be achieved through this roll-up strategy. And smaller companies often trade at a lower valuation multiple, right? Something like price to earnings ratio or EBITDA, right? And then compared to the larger one and more stable companies. And when a PE firm acquires these smaller companies and integrates them into the larger company, the overall business may command a higher valuation multiple due to the increased size, stability, and market share. So then the firm then can sell that combined entity at a higher multiple, achieving a profit of the increased valuation. So hence the term multiple arbitrage. So then you might be asking yourself, how are these deals financed? Okay. So here's a kind of a visualization that I like to show people. So let's say that you have a private equity firm, also known as the sponsor, and they want to target this hospital for acquisition. Okay. The target's valuation is at about $1 billion. However, the private equity's equity, or the money that they have on hand, is $500 million. So they need capital to raise, they need $500 million in capital to make this acquisition. Okay. So this is where an investment bank or an arranger comes in. And that arranger goes out and finds a syndicate of lenders, right? So typically with a syndicate, right, you're not just finding one lender. You're finding multiple lenders to spread that risk around, just in case the hospital or the nursing home goes belly up, right? And that spreads that risk around, and not one lender is being hurt, over that. And so, after this, let's say that the private equity firm, after, they make the successful acquisition, they sell it for $2 billion, right? They return to the lender $500 million, and the private equity's profit is $1.5 billion, right? But one thing to note here is they only used $500 million of their own money, okay? And the debt that's placed on that hospital or that nursing home, although the PE firm initiated the deal, that debt is loaded onto the hospital. So when a private equity firm buys a target under this, what we call a leveraged buyout model, the firm pledges the target's assets as collateral for the debt to finance the purchase. So notably, the acquired entity, not the private equity firm or the sponsoring private equity fund, bears the responsibility of repaying that debt. So in a typical private equity financed acquisition of, of a nursing home or a hospital, approximately 70% of that overall cost of that transaction is financed by debt. And the private equity fund provides the remaining 30% equity stake, right? And that 30% equity stake is funded primarily by the limited partner or the investors, such as the endowments, the pension funds, and wealthy individuals. With the private equity firm contributing about 2% of the overall 30% equity stake through its general partner, which then manages the acquired business and typically make up the principals from the private equity firm. And then due to corporate practice and medicine laws, this is especially relevant for physician practices. They create this, what we call an MSO model. So essentially, by state law, most physician practices especially can only be owned by the clinician. So to get around that, what the private equity firm typically does is creates a management service organization. And then it acquires the administrative or the non-clinical parts of the physician practice to the MSO. And then the management company takes care of the administrative, the back-end office functions, and then they're paid a management fee for that. So they're not directly owning the clinical part, but the administrative and the non-clinical assets of the practice. So, there's been a flurry of these acquisitions over the last decade. And I always like to bring up, is this actually history repeating itself? Well, maybe, right? If you go back to the 1990s, there were the publicly traded physician management companies, all right? And Uwe Reinhardt called it finance gimmickry, the great health economist. And so I use this example here. Suppose a large platform nursing home wants to acquire a smaller nursing home, and they have a price to earnings ratio of 25-1, with annual earnings of 1 million and 1 million shares outstanding. Each share sells for $25. Okay. That target practice trades at a price to earnings of 10-1, and annual earnings of 100,000 and 100,000 shares outstanding. Each share sells for $10, right? Then the platform nursing home offers stock-to-stock options. one share of the platform practice is offered at $25 in exchange for 2 shares of the target practice at $20. That platform then issues 50,000 shares to finance that deal. So this increase in the earnings per share from 1 million to 1.5 million, and the price to earnings ratio here is 26.5. So what happens when there's no more targets, right? There's no room for growth. And then the whole thing collapsed. Now, I think this is a little different now, but I like to put this example in there that, hey, just raise a little eyebrows here that, that we've seen this before in different flavors. And, it wasn't a very good outcome in the 1990s for these physician management companies. And so the controversy, right? Especially young clinicians, right? They may work for decades at an income level discounted from pre-acquisition levels when they get acquired by a private equity firm, and they face significant buy-ins to profit from the second sale. There's also very high turnover. And there's also, as you've probably noted in the news and the media and some empirical research, there's a lot of market failure and loopholes that the private equity firms have exploited, such as surprise billing, which led to the No Surprisings Billing Act, and Medicare's payment of physician administrated drugs under Part B is tied to a percent of the drug's average sale price, right? So there's incentives for physicians to prescribe the more expensive drug among competing options. For an example, macular degeneration injection drugs in ophthalmology are very expensive, and they comprise about 15% of Medicare Part B's cost. The other big issue is stealth consolidation. All right. So under the Hart-Scott-Rodino Act, it mandates that all mergers and acquisitions must be reported to the federal government of a deal value of above $101 million, right? But if you're buying small nursing homes at a very high clip that are all well under that $101 million and you roll them up, right? None of that has to be reported to the federal government. And so let's say you do 101 of these acquisitions at $1 million, right? That enterprise value of that private equity firm acquiring those nursing homes is much higher than that $101 million, but it didn't go reported to the federal government, right? And that is a major issue. And so this raises antitrust concerns. And there's also, increase of overutilization, overbilling, or upcoding, especially with these nefarious actors. I don't like to paint private equity with a broad brush, but, there are instances of, outright fraud and upcoding in these types of organizations due to trying to maximize profitability in such a short period of time. And then also another big concern is the replacement of physicians with advanced practitioners. So we set back a couple years ago to examine the phenomena of private equity firms acquiring nursing homes and its effects on quality of care and cost of care for long-stay residents. So we built this longitudinal database going back, prior to 2010, upwards of 2021, to examine these very issues. Here you can see a map of the locations of nursing homes that were acquired by private equity firms from 2013 to 2017. You can see it's pretty geographically dispersed with high concentrations in the Midwest, Florida, parts of Texas, and parts of California, and some parts of the Northeast as well. And through these results, we did a difference in difference framework. So we looked at when an acquisition occurred, what did their quality look like before acquisition, and what did it look like after acquisition relative to other for-profit nursing homes that were never acquired, okay? And what we found was there was after acquisition by a private equity firm, there was about 11% relative increase in the number of ED visits, an 8.7% increase in hospitalizations, and total costs increased 4% per quarter. That's not by year, but per quarter, right? So quality, these are validated claims-based measures as a proxy for quality of care in nursing homes. So what we came to the conclusion is that when a private equity firm acquires these groups or these nursing homes, quality goes down and cost goes up. And so then this leads into the other big form of institutional investment in nursing homes. These are real estate investment trusts. So with my colleagues, Dunk Williams, David Stevenson, Larry Castellino, Arian Jung, Raul Fernandez, and Mark Unruh, there was no literature on what REITs actually were, how they were defined, what their role was, and this is what this paper was about, and what its ultimate effects on staffing were, right? And so let's just jump into what a REIT is. It's not as clear cut as what it is with private equity, all right? But these are for-profit, public or private corporations, and they invest in or fully own income-producing properties, all right? And they're known as pass-through entities. These are the tax exemptions if through a pass-through entity, they have a tax-preferred status. So tax exemptions if REITs satisfy a series of requirements related to sources of income and assets. This includes dispersing 90% of their taxable income to shareholders annually in the form of dividends. If these requirements are not met, they lose that tax-preferred status. So what if a facility is not affiliated with a REIT? What is the most valuable asset that a nursing home has? It's the actual real estate, right? So if you separate the property from the operations through what we call an OpCo-PropCo structure or operating company, property company, you can generate additional revenue that is only taxed at capital gains, okay? So if a nursing home is not affiliated with a REIT, the nursing home pays taxes on the profits generated from its operations, and then the investors in the nursing home pay taxes on their share of the profits. This is known as corporate double taxation, which REITs are designed to avoid, okay? So what is a REIT structure? The first and most common one in nursing homes is the triple net leasing agreement, okay? So the REIT acquires the nursing home operator's property and then rents it back to the operator under a long-term lease. Think of this as your typical landlord-tenant relationship. And this is the more traditional model in the nursing home space. And the operator pays all the expenses of the property, including the taxes, the building insurance, and maintenance. So in addition to the rent and utility costs paid to the REIT by the operator. And then one thing I want to stress here is that they're prohibited from directly operating and collecting revenue from the nursing home operations, or they lose that tax preferred status, okay? The other one that kind of more follows along with private equity is what we call the RIDEA structure, or the REIT Investment Diversification and Power Act of 2007. This is used to generate additional management contracting revenue for the REIT, okay? They're allowed to collect taxable revenue from the nursing home operations, okay? And then the REIT leases its property at arm's length or at fair market value to a taxable REIT subsidiary, or what we call a TRS, which the REIT owns. And then that TRS then contracts with an independent nursing home operator. But that REIT can own up to 35% of an independent operator and allocate up to 20% of its total assets in one or all of its TRSs. So like in a triple net leasing agreement, the operator pays all of the property expenses. And then in the REIT TRS, because of this, receives a management fee for dedicating employees and time managing the property and providing operational guidance. And then if the operator can reach certain financial metrics and quality metrics, incentive payments are often given to that operator. So I know that was just like, I just threw the kitchen sink at you there, but here's kind of a simple visualization of this, all right, of a RIDEA structure. So in this simple RIDEA structure, the REIT, or the real estate investment trust, leases the property to the TRS, right, known as the taxable REIT subsidiary that they own. Then that TRS then contracts with an independent nursing home operator that can provide nursing home care in its REIT-owned properties. That TRS then may collect taxable revenue for basic services such as laundry and cleaning services. And then that REIT can allocate 20% of its total assets in one or all of its TRSs. All right. And then the operator still pays rent and the building costs. And then profits generated from the nursing home operations by the REIT and TRS under this structure are then passed to the holding company or shareholders that commonly own them. And then alternatively, REITs can be independent from that holding company demonstrated by that dotted line right there, connecting the holding company and the REIT, and then directly distributing those profits to shareholders. And in some instances, that nursing home operator may be owned by the holding company, and they may own the REIT as well, demonstrated by that also that other dotted line connecting the holding company and nursing home operator. And then that REIT can directly own up to 35% of that nursing home operator, as I mentioned before. So I hope that visualization helps a little bit. In these leases, typically with the triple net leasing agreements, even in the RIDEA structures, they typically have rent escalators in them, right? So every year they typically increase the rent 2 to 6%, or it's tied to inflation. And these screenshots here are just from basic 10K reports of publicly traded REITs that have a large portfolio of nursing homes, demonstrating that, hey, it can be tied to, the consumer price index, where, as staffing costs go up, and, reimbursement has been pretty stringent or declining, especially in the Medicaid population, right? And high periods of inflation, this can put nursing homes at risk. All right. And that is one of the pitfalls of these REIT agreements, or these sale leasebacks. But you might be asking yourself, why are nursing homes selling their nursing homes or their actual physical property to a REIT, right? Well, it could be an appealing investment. There's tax advantages. And from the REIT side, demand for nursing home care services. So they think that, relatively there's stable demand or growing demand for nursing homes. So it's a good business to be in. And relatively predictable reimbursements from Medicare and Medicaid. And then related parties, that's a topic for another day. I would love to get into that discussion later. More to be determined on that, hopefully, with a paper coming out soon. And then what are some of the advantages for nursing homes? Well, there's a master's lease agreement. So in this scenario, the operator pays an aggregate base rent to the REIT for all the facilities at which the operator provides care. This provides the operator flexibility in allocating resources across facilities, right? So if one individual nursing home is not performing financially well, and another one is, this can kind of cross-subsidize that and cancel out risk, right? And REITs can help create efficiencies, right? They can provide proprietary IT infrastructure, layers of quality performance monitoring, facilitate group purchasing, and provide operational expertise. And more importantly, the infusion of capital to conceivably improve quality of care, modernize their facilities. And the operator can focus on brand strength, market share growth, customer experience, and clinical care, and they don't have to focus on the real estate itself, which is a whole nother responsibility, large responsibility. And this is just a snapshot from a slide deck from one of the publicly traded REITs out there. And they say that we offer more than just capital. We are a partner in our operator success. We improve operating efficiencies, share best practices, facilitate group purchasing, share operational expertise, right? They help with, redevelopment, expansion, and strategic development. And one of the interesting things is, as a REIT, especially if you're a triple net leasing agreement structure, you're not supposed to be providing any guidance on the clinical care itself, right? But I found this pretty interesting that, providers, this REIT provides more than just capital. It's a partner in the success by providing industry metric intelligence, purchasing leverage, and important healthcare perspective, right? So they're using, their IT infrastructure, their quality monitoring to help guide nursing homes to achieve profitability and conceivably improve quality of care, which we'll get into here in a second. But what are the disadvantages that put operators at risk? Rent escalators, which I just touched on, rising cost to operate, poor reimbursement, and the triple net structure minimizes risk to the REIT. Lease revenue remains consistent regardless of the operator's financial performance and inflation. And then under the RIDEA structure, these financial incentives may not align with resident care. And so critics argue that these complex ownership structures limit REIT liability or piercing the corporate veil. So let's say there's a wrongful death lawsuit and a family wants to sue within that nursing home operator. on their balance sheet income statement, it doesn't look like they're profitable because they're shifting most of the assets through the REIT up to the shareholder company, to the holding company. And so there's nothing to sue because they operate at a loss, right? And so piercing that corporate veil is pretty hard to do. And that's what most critics say about this. And, here's just a snapshot of a story about, senior care centers files for bankruptcy blaming expensive leases, right? There's a lot of anecdotal evidence out there. And so we looked at these REITs and tried to describe what they are and look at their geographic distribution across the United States. And in 2021, there were about 1,800 nursing homes that had REIT investment. These REIT nursing homes were in the lower 48 states, with 42% of them located in the South, 27% in the Midwest, 19% in the West, and 12% in the Northeast. States with the largest number of REIT-owned nursing homes were in Texas, Florida, California, Indiana, and Ohio. And then REIT nursing homes with the highest proportion of total beds in a hospital referral region were in Owensboro, Kentucky at around 66%, Lakeland, Florida around 64%, Boulder, Colorado at 60%, and Terre Haute, Indiana at 56%. And these are the biggest nursing home operators that have REIT-owned facilities. Genesis, Ensign, Trilogy Management, which is actually a RIDEA structure, HCR Manor Care, which is now ProMedica, and then Consulate Healthcare. All these other than Trilogy were in triple net leasing agreements. And these are the top 5 REITs in the nursing home space: Omega Health Investors, Welltower, CareTrust REIT, Sabra, and Griffin American North Star, which is part of Trilogy Management. And so here we did a difference in difference to examine when a REIT makes an investment in a nursing home and the nursing home sells its actual property, the physical property, to the REIT, what happens to staffing? And so we looked at, hours per resident day for registered nurses, licensed practical nurses, and certified nursing assistants. And what we found overall is that there was a 3% decline in registered nurses. This wasn't significant, though, and about a 2% increase for licensed practical nurses and certified nursing assistants. Now, one important note here I want to make is when you remove the 3 largest REIT deals, the signs flip and become significant. So there's roughly about a 3% significant decrease in RNs, while LPN and certified nursing assistants remained relatively stable. So one thing I want to say, one caveat is that no 2 REITs are the same, but it appears that the bigger REIT acquisitions or deals were actually probably performing where they were hiring more LPNs and certified nursing assistants, where the smaller deals tended to lower operating expenses for registered nurses. And here's just a visual demonstration here of that over time. And so what are the implications, right? An estimated 12% of nursing homes have REIT investment, and there's a substitution of labor after REIT investment. This is unknown whether this impacts resident care, but we'll get into that in a second. And not all deals are the same, and there must be organizational ownership transparency. CMS, currently focuses only on a facility level, which is important, but understanding the parent company is very important as well. And we need a longitudinal CMS ownership data, which CMS and the president of my administration are being very proactive in trying to achieve. And there's also no standard way to define what an institutional investor is, at least in CMS's eyes, right? That's changing though. In other words, like, how do you define private equity, REITs, venture capital? So I came up with the idea of, just reinvent the wheel here. No need to reinvent the wheel here, is you can use the SEC filings of a Form D to make a standardized way of doing this. And Rule 503 of Regulation D of the Securities Act of 1933 is part of that. And so now getting into the quality of care. So we were commissioned by ASPE to look at trends in ownership structures of nursing homes and their relationship with quality of care. Same story here is you can see the prevalence of REIT and PE investment over time. And as you can see, that REITs have steadily increased while private equity has been slowly exiting the market. And then what we do here is we look at health deficiencies before and after an acquisition takes place. And these are the results after private equity firm acquires them, and along with staffing. And what we can see is there's a 14% increase in health deficiencies, while there's about a 12% decrease in RN hours resident per day, with no changes in LPNs and CNAs. Same story with REITs. We see about a 14.5% increase in health deficiencies, about a 7% decrease in RN hours per resident day, and no changes in LPN and CNAs. So they're decreasing RNs because they're the most expensive form of clinical care, to try to increase their profitability. So all of this comes to a head to identify how good is the ownership data that's currently on CMS's website. And so we used our REIT and PE data to see what we're tracking and what CMS is tracking, currently in those ownership files. And what we found that, ownership percentages were missing in the CMS data for about 82% of owners in the top 10 nursing home chains, and 55% across all owners across the United States. So this leads to, a summer of major policy reforms needed, right? We need to establish adequate evidence-based federal staffing minimums with adjustments for resident acuity, strengthen enforcement, especially on chains and institutional investors, increase ownership transparency, and set federal certification criteria for ownership, require greater financial transparency and accuracy, and improve financial accountability with direct care spending requirements and return of excess payments. But one other thing just to remain a little more neutral, if anyone watched Jerry Springer back in the day, here's my final thought. We should be also considering or including policies that incorporate capital market dynamics. Policy making focusing on a small percentage of the industry, such as private equity and REITs, can unintentionally sever access to capital. And because nursing homes are very capital intensive, right, access to this type of funding is very, very important. And that concludes my presentation. Thank you.
Tyler, thanks so much. That was so informative and interesting, and a lot of interesting comments. I'm going to share my screen and do a couple of outro slides. Just 1 second. Just gonna share. Oops, sorry about that. Let me try that again. For some reason my files are not coming up, so pardon me. I will share. There we go. So once again, I just wanted to mention that next month, instead of our normal webinar, such as today's webinar, we're going to be hosting a panel discussion in the early evening. It'll start at 7 p.m. Eastern time. That's April 16th. I think Haley posted the link in the chat, but you can join us in person for a cocktail reception in New York City, or you're welcome to attend the panel discussion. I think it's going to be really interesting. As I mentioned before, we have 4 just great panelists from government, from advocacy, from practice, and from investigative journalism. And Amy Sheffrin, who is going to be moderating the panel, is extremely smart, and she's just really engaged on these issues. So I hope you'll join us next month for that. And again, we are on Instagram. You can scan the QR code to see that. We're posting a lot of our materials as well as our family empowerment programs, etc., on Instagram. And then lastly, head to Nursing Home 411 for materials from today's webinar. As I mentioned earlier, we're going to be posting the recording of the program by the beginning of next week. You can see information about sponsoring or advertising for our program next month, the panel discussion. We would certainly welcome that. And then follow us on Instagram at LTC Coalition and visit our website for our fact sheets on nursing home care standards, including our dementia care advocacy toolkit, our assisted living guides, family empowerment resources, and our family empowerment project, and the resident abuse, neglect, and crime reporting center. And with that, I'm going to open it up to questions and stop sharing. And I'll go through some of these questions here. We have about 7 minutes left. So some of these are really basic but interesting. The first one, Janine Ferrari asked, does your analysis apply to Department of Health run VA nursing homes too? So I guess I would say, does it, I mean, so she's referring specifically to VA nursing homes that are part of the CMS system, not under the VA. But I think it would be interesting to hear about the extent to which, well, I guess they wouldn't apply to government-owned facilities, but you answer, I'm sorry.
Yeah, correct. So we focus strictly on for-profit nursing homes, or those that were nonprofit that were acquired. But our control group was strictly for-profits that were never acquired.
Great, thanks. Sam Kukic, I hope I'm pronouncing your name correctly, asked, how do private equity and related party transactions interact? There are millions of dollars being made by owners. I know that's a huge question, as you said, and
Yeah.
I completely agree. But I don't know if there's any quick takeaways that you could share.
So unfortunately, in the national HCRIS data or the cost reports, the related party data is just not well documented. As Richard and Charlene and I were trying to, dive into this, it's just really, really messy. So like, it's really hard to try to define just how those are interacting. Now, there's a recent paper out by Ashvin Gandhi and another colleague that looks at this called tunneling. And what they see is that don't quote me on this, around 63% of nursing homes are doing this tunneling or hiding profits through this. I highly recommend it. It's a very interesting read. But they're using only the state of Illinois cost reports for that. So it's not truly nationally representative, but we need more financial transparency to understand this, at least on a national scale.
Thanks. Sam also asked, why doesn't CMS hold a tighter rein on what is happening?
I'm not really sure. I think that, it kind of comes down to a lot of elements. First is we're, a capitalistic market. And so the government isn't, here to tell you who and who cannot get acquired, unless it has antitrust concerns. I think the second part comes back to that Hart-Scott-Rodino Act I was talking about with that $101 million threshold, right? If you're doing deals that are well below that and you're doing lots of them, right, it doesn't have to report to the federal government, right? So, there needs to be some thought process in how to revamp that and revise that so that you can see these smaller deals going on and how that might have antitrust concerns. I think that's the major issue there.
Thanks. Thank you. Karen Klink asked two questions. One, can you explain or define what the term, the term platform?
Yeah, sorry if that wasn't clear. So typically what a private equity firm does is they acquire one of these platforms, or typically a well-run nursing home or nursing home chain in a community. And then they use that platform to go out and acquire individual nursing home facilities or physician practices, and then they roll them up into that big platform practice to make it even larger, right? So the platform is operating on the behalf of the private equity firm to go out and make acquisitions. So typically a private equity firm is only making the acquisition of that chain, and then that chain goes out and acquires those individual facilities.
Thank you. She also asked, and you got at this a little bit in terms of with the maps, but I don't know if you have the answer to this. What is the percentage of SNFs owned by private equity or real estate investment trusts?
Yeah, so for REITs, it's roughly around 12%. Just to make a clarification here, REITs don't own the operations themselves. They own the property. So I always say, I try to make a clarification, REIT invested, right? For that. And then for private equity, it ranges, depending on wherever you look at, it's around 5 to 11%, but it's probably more closer to 5%. And if you look at that slide on showing those prevalence and trends over time, it peaked around 11% and they've been slowly exiting out.
Yeah, it's interesting. I was just talking to a class yesterday about some of those trends with private equity and how it came in and now seems to have really deflated. Um, Chris Carlson asked a really interesting question. I know we only have a couple of minutes left, but he said the lesson here seems to be that the deal finance cycle is more harmful than beneficial. As advocates mapping our local deal finance landscape, should we be trying to create a landscape that bucks facilities off the deal finance cycle by making them less desirable for platforming, et cetera? If that is the correct lens, what high impact tactics or strategies do you recommend based on your research to date?
Oh, all right. Let me read this. The
Oh, can you
lesson.
see that? Okay.
Yeah, I see it. Deal finance is more harmful than beneficial as advocates mapping our local. Should be trying to create a deal by making them less survival for platforming. I guess I'm a little confused on less desirable. I'm not sure what that means, but if Chris wants to shoot me an email to clarify it, I can definitely give it a little more thought.
Sure, thank you. And what I took from that is that it's something I've been thinking a lot about is how do you make the industry, I mean, we have the industry structured the way it is, and that's not going to change probably anytime soon. But how do you make it so that it's less attractive to predatory operators? I
Hmm.
think I take back,
Right.
to where we were 20 years ago, or maybe even earlier than that.
Yeah, I
Yeah,
think probably having more skin in the game. If you're
mm,
only using 2% of your own funds and then 30% from outside wealthy individuals or endowment funds, right? And you're borrowing on the revenue of the nursing home itself to meet those debt obligations, I think they need to have more skin in the game, if that makes sense.
yeah, yeah. Um, One last question. This is from Marina Thornton. How can the CMS ownership of nursing homes data be improved to address the gaps in reporting that exist and increase transparency around ownership?
It's a really good question. I think that, if I had a wish list, I think the first thing that we want is a longitudinal data set that tracks it over time. Um, we would want individuals that have stakes in it. We want the facility ownership, but we also want the parent company and all its related parties that actually own it as well. It's a very big web, and how that data will come out, I'm not sure, but that would be on my wish list.
Great. Thank you. Tyler, thanks again. Just so interesting and informative and such important issues. I appreciate it. Thank you, everyone, for joining us today and hope to see you next month. Have a nice evening.
Feel free to email me too if you have questions.
Great.
All right.
Thanks.
Bye.
Bye-bye now.